Welcome to AETCM, the Emergency Medicine Channel. Today we are going to discuss a 46-year-old female who came to ER with presentation of deviation of angle of mouth. Let's tell this. A 46-year-old female was rolled into ER with complaints of the weakness in angle of deviation of mouth to the left side. On arrival, primary survey, initial airway was patent, patient was able to talk in one full sentence, breathing saturation was 99% and respiratory rate of 18 per minute, bilateral air entry equal and no added vascular breath sounds. Next, circulation, pulse is 65 per minute and BP is 150 by 100 mmHg, peripheral pulses are palpable. And two IV cannula was put in and samples were taken at this point. Regarding disability, GCS was E4, V5, M6 and pupils were bilaterally reactive. Ma'am. And next, coming to exposure, temperature was febrile and GRBS was 125 mg per DL.
When was the onset?
Regarding the onset, it was today morning at 7:30. Patient arrived to our ER at 6 o'clock, ma'am. 6 p.m. Morning at 7:30, the patient started developing weakness.
Okay, so patient came after 10-11 hours.
Out of window period.
Okay.
So, as per the primary survey, patient has no any acute interventions, and patient coming to the secondary survey, patient is a known case of.
Primary survey only intervention was GRBs.
Okay, patient is a known case of SLE lupus nephritis with known case of hypertension and young stroke. The lupus nephritis, she even had APS triple positive and recurrent abortion history was also there in the patient. And the patient is on immunosuppressions with taking MMF and MMF. And she had chickenpox on 1 month ago, which she was being treated with antivirals. This is the past history. And on arrival to the ER, she had complaints of the presenting complaint is patient is having deviation, angle of deviation to the left side since the morning, and associated with that inability to.
So secondary survey, what will be you ask? Sample history. What will you ask? Signs and symptoms. Then allergies. Is she having any allergy?
No any allergy.
Medications you have already told. Past illness you have already told. And last meal.
Last meal was in the afternoon. Okay. She had the food.
Okay. Then events
are when she woke up in the morning, she started noticing that there is a angle of deviation of the mouth towards the left side, which had been there in the morning, but it has been acute in the afternoon, and it was progressing by the afternoon. Apart from that, inability to close the right eye, and even drooling is also noticed from that.
Which side?
Drooling is noticed from the right side. And
so patient's angle of mouth is deviating to the left side means patient's weakness is on the right side. So drooling will be on the right side. And inability to close the eyes on the right side. Okay.
And negative history wise, she had no any ear infection, or she doesn't have any hyperacusis, no loss of sensation taste, no loss of sensation over the face.
Why you ask that history?
Ear infection because the facial nerve will passing through the ear. If any infection of the ear or any discharge can involve the facial nerve and cause such symptoms.
So LM facial nerve palsy can happen if the ear is infected. Okay.
So initially on arrival, when we see in the left-sided angle deviation and such, we would be expecting a focal neurological deficit, and we should be first considering about if it's a stroke or not. As the patient is out of window period, we had taken the secondary history, evaluated, and then proceeded. So in the secondary history, we
need to differentiate whether it is upper motor neuron or lower motor neuron. So history-wise, we are getting it as inability to close the eyes is there, deviation of angle. History-wise, with the background of chickenpox, we are feeling it as like
element Palsy.
So what else will you ask? So we have told about the facial nerve. In the history, you are telling about hyperacusis, difference in sensation. Why are you asking that?
Because branches of the facial nerve, we wanted to see where the basic nerve is started to affect. Is it just the motor component, distalmost component, or even in the intrameatal part where it gives branches to chorda tympani, greater petrosal nerve? Even are these also are involved or not?
Okay.
If they are involved, we will be knowing till where the
which all are the distal branches?
Distal branches are the 5 motor branches: zygomatic, buccal, cervical, mandibular.
So it is actually zygomatic, then
Temporal, mandibular, buccal and cervical.
Marginal mandibular, cervical. Okay. And just before that it will supply what?
Before that it will
So that is the motor branch. 5 motor branches are there for the face. Then
in the internal meatus it will be giving 3 branches: greater petrosal nerve, which will help in secretion of the lacrimal gland, and another is nerve to stapedius, because of which hyperacusis can be the symptom.
So if nerve to stapedius is affected, patient will be having hyperacusis. Otherwise it is not like reduced hearing, patient will be having increased hearing. Okay.
Next, if the chorda tympani branch is affected, anterior 2/3 of that side of the tongue would be affected in the taste sensation. Same side.
Okay.
This branch.
So it is having 5 motor branches there. That is the distal most branch, and the it supplies only one muscle, that is the nerve to stapedius, and only sensation is the tongue. So what will supply the sensation of the face?
Sensation of the face is supplied with the trigeminal nerve essentially. So that is intact.
Okay. So if suppose a patient is having difference in sensation over the face, what will you suspect?
If there is a difference in sensation, then if it is a long-standing like this facial nerve palsy, element palsy, long-standing, then because of the laxity of the muscles, there can be a difference in sensation. But if it is like an acute presentation, then we should be considering that trigeminal nerve is also involved, and central pathology is the cause of this situation.
Upper motor neuron should be
Upper motor neuron. Regarding this further, DDs would be, we can consider otitis media and otitis.
So you are suspecting more towards like a element facial palsy. So before that you need to examine. How will you examine?
Regarding the examination, we would be actually doing the facial nerve testing. So facial nerve has the motor branches. So first we check the wrinkling of the face by asking the patient to look upward. When he is trying to look upward,
look upward by
fixing the face.
Fixing the face.
So that the wrinkles will be formed. If the absence of wrinkles is there, then it means the facial nerve, which is innervating the eyebrow, this forehead muscles, is not working. Apart from that, we check for the closure of the eye. We can, in this patient, it is not closing, so it's evident directly that it's not.
So we have to ask the patient to close the eye against us. So we will be trying to open it. Patient have to close. Okay.
Or even showing sudden jerky movements towards the face, causing it illicitly to close the eyes. Also, we can check. Next coming would be the asking into nasolabial folds. The absence of the nasolabial fold on that side would be saying that there is no vessel weakness on that same side. And then to clench the teeth or smile so that orbicularis will be, to see the function of the orbicularis. If it's not functioning, that side it will be drooping, and other side it will be deviating because the other muscle is functioning.
Okay, it will deviate to the opposite side.
And as is the muscle weakness on the same side, the drooling of the saliva will be seen, as it cannot contain the saliva. These are the motor functions. Apart from that, muscle waste.
Platysma also will be involved. Okay. So these are the things. Then that is a motor which we examine. Along with that, we will have to examine the taste sensation also. Then
but in ER it
will be difficult, and for hyperacusis also it will be difficult. So we will be able to assess only this much. So what will happen in LMN?
In LMN, basically, as it's a lower motor neuron palsy, one side of the face will be completely affected. Whichever the nerve is spreading.
So from the wrinkling of the forehead, everything will be there.
One whole upper and lower part, both of the face
involved. UMN?
In UMN, corticobulbar will be giving its connection to bilateral facial nerves. So the opposite nerve will be taking control, and only the lower half of the opposite side will be affected in upper motor nerve.
Okay. So, what all will cause bilateral facial nerve palsy?
Any tumors in the pontine region,
Okay.
and infarct as in stroke.
It should be bilateral, no? Causes of bilateral facial nerve.
Lyme's disease is in
Snake bite can be there. Then
GBS.
myasthenia, unlikely. GBS can be there. Miller-Fisher variant of GBS. So facial nerve palsy can be there along with ataxia, and patient can also have this thing, ophthalmoplegia also will be there.
Then Lyme's disease is one DD which will have bilateral involvement.
Then sarcoidosis can be there.
Any immunocompromised.
This patient already has some autoimmune condition also.
It's immunocompromised along with the past history of varicella zoster is there in the patient, so highly indicative that it can be herpes zoster this time, which has that.
Sometimes this patient, since this patient is having element facial palsy, we will be able to get these manifestations like entire face is involved. So wrinkling, this closing of the eyes, Bell's phenomenon. What is Bell's phenomenon?
Bell's phenomenon is the lid like not able to close the eyes. Is the Bell's phenomenon?
No, it is not able to close the eye. When we are closing our eyes, our eyeball will look up. It will move upwards. We won't be able to see that in a normal individual, but we will be able to see that in a patient whose eyeball is who is not able to close completely. So that is called as Bell's phenomenon. Then one more test we will be able to do is ask the patient to blow the mouth. If the patient is not able to hold, that is also indicative that patient's facial nerve is affected.
And the special function test has hyperacusis sensation. Even lacrimal test can be done with Strimmer's test to see if the lacrimal gland is secreting the tears.
Okay.
Regarding this patient,
what are the other nerve which is innervating the face is the trigeminal nerve. What all things will you check if we are suspecting a trigeminal involvement?
Trigeminal corneal reflex we can check.
Corneal reflex, conjunctival reflex, that is a sensation.
And then we will check for the touch sensation.
So pain, temperature, touch of the face. So bilateral face area, trigeminal is having 3 branches. Which are they?
Ophthalmic,
maxillary, mandibular. So ophthalmic region, maxillary and mandibular region of both sides we need to check for the touch sensation and the temperature. All these sensations should be checked. Then the reflexes, corneal, conjunctival. One more reflex. Jaw also we need to check. Then muscles of mastication. Okay, muscles of
that will be provided with fish.
Muscles of mastication is supplied by trigeminal nerve. So what all will you check?
Protrusion of the jaw.
No, ask the patient to clench the teeth. Clench the teeth. That clenching the teeth will be supplied by the masseter and the temporalis. So we will be checking that. Ask the patient to open the mouth against resistance. So if the patient is able to do that, that means lateral pterygoid also normal. Okay.
Now in this patient, coming to the treatment part.
So if you are confused between LMN and UMN, what will you do? What else will you elicit in the patient?
UMN and LMN only the
if it is not very classic and if you are having doubt. So will you do an MRI in this patient?
In this patient, preferably not, as it is suggesting of everything.
It is suggesting of LMN. So when will you do MRI?
When there is any atypical presentation, if the absence of upper part of the face is not involved, then better to go with MRI initially. Or actually clinical presentation itself will be a clue. If it is just sudden acute onset, then MRI is required, as it's a progressive event which is increasing. Usually this kind of Bell's palsy is a progressive kind of event which increases within 1 to 3 days and stays over 4 months and gets resolved spontaneously. This is the progressive trend. If it is not resolving even after 4 months, then again MRI would be required to see if there is any tumor causing this.
Then in the ER, when will you plan on doing it? That is chronic case. In the year, when will you plan?
Acute presentation, it better to rule
Acute presentation is not to rule out specific indications. If at all the patient is having some other weakness, other involvement.
other neurological deficit along with this, then
Other neurological deficit that can include limb weakness, or if the patient is having, we need to examine the cerebellar. Look for cerebellar signs. If cerebellar signs are also becoming positive, then we need to do MRI. Otherwise, if it is classical LMN visual palsy, no need to do. Okay.
So in such
So what all are the causes of LMN facial nerve palsy?
element like herpes zoster,
Herpes zoster.
then even pregnancy third trimester edema can and other viral like even recently COVID any vaccines are post-vaccine, there can be such reactions. Even recently COVID vaccine reactions are having Bell's palsy.
Okay. How will you treat?
Regarding the treatment, first we will
Even otitis media can
otitis
also cause. If it is becoming chronic otitis media.
So first we divide it into the treatment part includes treating the facial weakness part and also about taking care of that opening eye. So regarding the opening eye, if it is unable to, there is inadequate adequate eye closure, nothing much to be given to the patient. But if that's inadequate, we need to take care of the tear drops. So when during the day and during the morning, we need to be installing teardrops so that the eye will be dry. Exposure keratitis won't be causing. And during sleep, we need to cover with the bandages. Next, regarding the grade of the facial weakness, we have a scale of weakness. House-Brackman classification. Depending on that, we divide it into normal, mild dysfunction, moderate dysfunction, moderately severe dysfunction, and severe dysfunction, and total paralysis into 6 classes. Classes from 4 to 6, if that is called severe, and below 4 it is mild to moderate classification. In mild to moderate classified facial nerve palsy, steroids is sufficient, but if it is moderate to severe, there along with steroid, antiviral such as acyclovir or valcyclovir is required. Regarding steroid doses, we give prednisolone 60 to 80 mg daily till 7 days. And regarding valcyclovir, 1000 mg.
After that?
After that, you no need to tape.
1 week is fine, but
after that follow-up, we have to see if there is a recovery, well and good. If there is incomplete recovery, then we can consider botulinum toxin and other
that is if it is becoming chronic. If the patient, usually how long will it take for the patient to improve?
On treatment within the 1 week duration, 1 to 2 weeks.
Unlikely, sometimes it might take up to 6 to 9 months for the patient to improve. So initially after starting steroids, after 1 week, since if symptoms are persisting, you can continue the steroids, but in tapering dose. So if you are starting it as 60 mg OD dose, after 1 week you can change it to 50 mg OD for 1 more week, then 40 mg OD. Like that you can taper and stop.
And regarding the antivirals, valcyclovir is 1000 mg 3 times daily for a week, or acyclovir it is 400 mg 5 times a day for 1 week.
Okay.
Apart from that, phase physiotherapy exercises would be required if there is a persistent weakness. Even after 4 months, if it is not resolving, then repeat MRI to evaluate if there is any slow growing tumor causing such changes can be done. In our patient,
so MRI that should include the ear area and the parotid region also, not only the head. Okay.
In our patient, we had given the start dose of steroids in the ear, and as the patient is a known case of immunocompromised state with herpes zoster in recent infection, considering it to be Bell's palsy, we had discharged him on OD 60 mg of prednisolone along with that valcyclovir of 1000 mg TID for 1.
Okay. Anything else?
Just
Okay, thank you.